Welcome back to the deep dive. We're jumping straight in today with something really common, but maybe a bit overlooked.
Definitely.
We're looking at impacted earwax or cerumen impaction using these brilliant high-yield revision notes. Perfect if you're prepping for the MSRA or, just want to get clued up.
Absolutely. And these notes, they're designed to be concise, hitting all the key areas you really need to grasp.
So think of this as us unpacking those notes together. We'll pull out the must-know facts, maybe some surprising bits, the really crucial clinical points.
Yeah, kind of a shortcut to getting well informed on this.
Exactly. You might think, earwax, how complicated can it be? But honestly, there's quite a bit here. Why it happens, who gets it, how we treat it, even some, well, pretty interesting stats. Let's get into it.
Let's do it.
Okay, so first things first, the definition. When we say impacted earwax, what are we actually talking about?
So the notes define it pretty clearly. It's the buildup, the accumulation of earwax cerumen inside the ear canal.
Yeah.
But the key part is that it causes an obstruction.
Right, an obstruction.
Yeah, enough of a blockage that it actually leads to symptoms. It's not just having wax, it's when it blocks things up and causes problems.
Got it. So it crosses a threshold from just being there to causing an issue. But what actually is earwax? What's it made of?
It's, well, it's actually quite a complex mixture. It's mainly cerumen, which comes from specific glands, ceruminous glands, in the ear canal skin.
Okay.
But it's mixed with sebum, that's oil from sebaceous glands, plus shed skin cells, sweat, bits of hair, and sometimes, dust or foreign material that gets trapped.
So a real collection of things. And it actually serves a purpose, right? It's not just gunk.
Oh, absolutely crucial. Its main function is protective. It helps trap dust, dirt, little particles, stops them going deeper. It also lubricates the ear canal skin.
Mm-hmm.
And it even has some natural antimicrobial properties, helps fight off bugs. It's meant to be good for the ear.
Like a natural defense mechanism. And the notes mentioned different types based on texture.
They do, yeah. It points out that wax isn't all the same. It can be wet, which might be soft, almost gooey, or sometimes quite hard, like a plug.
Okay.
Or it can be dry. That type is often described as flaky, maybe golden yellow. And this difference, wet or dry, can affect how easily it moves out or, how tricky it is to remove if it gets impacted.
That's interesting. So even the type of wax matters. Okay, it's protective, it's normal,
Yeah.
but then sometimes it gets stuck, it gets impacted. Why does that happen? What's the etiology here?
Right. So why does the system break down? The notes highlight a few main reasons. It starts with production, obviously, from those ceruminous glands.
Yeah.
Sometimes there might just be overproduction, too much wax being made. But maybe more often the issue is with migration.
Migration, how it moves out.
Exactly. Normally, tiny skin movements in the canal, helped by jaw movement when you talk or chew, slowly push the wax outwards, like a tiny conveyor belt.
Ah, okay.
But that process can get messed up. It might slow down, especially as people get older.
So the conveyor belt jams or slows down.
Kind of, yeah. Then there are anatomical things. Some people just have naturally narrow ear canals or canals with sharp bends or curves. That makes it physically harder for wax to get out.
Makes sense. Physical obstacles.
And then a really big one, something we see all the time, the notes really stress, external factors.
Yeah.
Using things like cotton swabs is a classic.
The dreaded cotton swabs.
Yep. People think they're cleaning, but they often just push the wax deeper, compacting it. Same goes for hearing aids or regular use of earplugs that can block the exit route and push wax back in.
Right. So even trying to help can sometimes make it worse if you're using swabs.
Precisely. It's counterproductive to the ear's natural cleaning. A really key takeaway point for everyone listening.
Definitely. So hearing aids, age, cotton swabs. That suggests some people are more prone to this. Who is most at risk? What are the main risk factors we should know?
The notes give a good list. Advanced age is definitely a big one. Partly because, as I mentioned, the wax composition changes, tends to get drier, harder, less mobile.
Okay, older adults.
Again, those structural things, narrow or twisty ear canals. And frequent use of anything that blocks the canal, hearing aids are a major one. And earplugs, too.
Right, the blockage issue again.
And yes, we have to hammer this home. Excessive use of cotton swabs, or really sticking anything in the ear canal. The notes are very clear on this being a major preventable cause.
That old advice, nothing smaller than your elbow, seems pretty spot on then.
Basically, yes. Other factors mentioned include having a lot of hair growing in the ear canal or certain rarer abnormalities of the ear canal structure.
Got it. So the wax builds up, gets stuck, causes a blockage. How exactly does that blockage lead to the symptoms people feel? What's the pathophysiology?
It's mostly mechanical. That plug of wax physically obstructs the ear canal.
Okay.
So sound waves literally can't get through properly to the eardrum. That's your hearing loss or muffled sound.
Like putting your hand over a speaker.
Exactly. Plus, the wax itself, especially if it's hard and pressing against the canal walls, can cause irritation, a feeling of pressure or fullness, even pain. So the notes list the common symptoms that result. Hearing loss, that blocked or full feeling, sometimes earache or actual pain, tinnitus, the ringing or buzzing sound.
Tinnitus too. Wow.
Yes, and sometimes even dizziness or a sense of imbalance. And if things get complicated, like a secondary infection behind the plug, you might get itching or discharge.
That's quite a range of issues from just wax.
It really is. And the notes also point out that over time, the wax can just get harder and more impacted, making it even less likely to clear on its own and making those symptoms stick around.
Okay, so someone comes in, maybe hearing loss, ear feels full, impacted wax seems likely. But you always need to think about other possibilities, right? What are the differential diagnoses? What else could it be?
Absolutely crucial, especially for exams. You need to know what else presents like this. The notes list several key ones. Ear infections are high on the list, particularly otitis externa infection of the outer ear canal.
Often called swimmer's ear.
That's the one. Also, fluid in the middle ear, behind the eardrum. A foreign body stuck in the ear canal. The notes mention this can cause sudden deafness, just like severe impaction, or even something like eustachian tube dysfunction.
Right, like a kid putting a bead in their ear.
Exactly. Then you've got things like a perforated eardrum, otosclerosis, which affects the tiny bones in the middle ear, and, much less commonly, growths or tumors in the ear canal. They can all cause similar symptoms.
So a proper look is essential to rule those out. Now, how common is impacted wax? What's the epidemiology like?
Well, specific UK prevalence figures aren't readily available, according to the notes, but they state it is extremely common in day-to-day clinical practice,
Okay.
especially in older populations.
Okay, very common.
It's even called a universal phenomenon because, well, everyone makes wax. But impaction is definitely more frequent in the elderly, people using hearing aids, and yes, those cotton bud users again.
Universal phenomenon really frames it. Any hard numbers?
There were some striking ones in the notes. An estimate suggests around 2 million irrigations are performed just for wax removal each year in England and Wales.
2 million just for wax. Wow.
Yeah, it gives you a sense of the scale. And prevalence rates mentioned in studies vary quite a bit depending on the population looked at, ranging anywhere from maybe 7% up to 34%.
That's a huge number of procedures, a significant healthcare activity.
It really is. And here's a point the notes make that I found particularly interesting, showing the broader impact.
Oh, yeah.
They mention a specifically high incidence reported in individuals with schizophrenia. And importantly, it can affect their functioning and even contribute to social isolation.
Wow, really? Impacted wax contributing to social isolation and schizophrenia.
Yeah, think about it. If your hearing is significantly muffled or reduced, it makes communication harder, potentially worsening feelings of isolation or paranoia. It just highlights how even a simple physical issue can interact with complex mental health conditions.
That's actually quite profound. A physical barrier impacting mental well-being and social connection. Okay, so back to the clinic. Someone comes in. What's the typical presentation and how do you actually diagnose it?
Well, the presentation is usually those symptoms we talked about: muffled hearing, blocked feeling, maybe discomfort, tinnitus. The notes reiterate it's especially common in older people, maybe because of more hair in the canal, the drier wax, maybe cognitive issues affecting care or hearing aid use.
Right, and confirming the diagnosis.
It's mainly visual. You need to use an oroscope or otoscope to look directly into both ear canals. You're looking for that wax blockage, assessing how much of the canal is obstructed.
So having a good look is key.
Essential. The notes also mention doing basic hearing tests like Rims and Weber's tuning fork tests during the examination. These can help confirm a conductive hearing loss, which is what you'd expect from a physical blockage like wax, rather than a nerve issue.
Okay, so direct visualization, maybe some bedside hearing tests. Are there other investigations mentioned?
The notes list two main ones, really building on that initial exam. First is otoscopy, that direct look. It's fundamental to see the wax and assess the situation.
The cornerstone.
Exactly. The other is an audiogram. This is a formal hearing test, usually done in a soundproof booth, to precisely measure the type and degree of hearing loss.
When would you need that?
It's not needed for every single case, especially if it's obviously just wax. But it's important if the hearing loss seems worse than expected. If you need to quantify it, rule out an underlying sensorineural loss or, document the hearing deficit caused specifically by the wax.
Right, for a more detailed picture. Okay, we've covered what it is, why, who, the mimics, how common, and diagnosis. Let's get to the management. How do we actually treat it? How do we get rid of the wax?
Right, the main goal is straightforward. Remove or clear that blockage to relieve the symptoms. The notes outline the standard approaches. Often, the first step is trying to soften the wax.
Soften it. How?
Using eardrops, called cerumen. These help break down or soften the wax plug, making it easier to come out on its own or easier to remove later.
What kind of drops?
The notes give examples. Simple things like olive oil or almond oil drops are often recommended. Or there's specific preparations like sodium bicarbonate drops, docusate sodium, or even urea hydrogen peroxide. Usually you'd use these for about 3 to 5 days, sometimes longer.
Okay, so try softening first. What if that doesn't do the trick?
Then the next common step is ear irrigation, sometimes called syringing, though modern methods use controlled low-pressure water streams.
Flushing it out?
Essentially, yes. Gently washing the softened wax out of the canal. The notes stress it's often much more effective after using those softening drops for a few days. This is typically done by a nurse or doctor. There are also some self-irrigation kits available, but caution is needed.
Right. And are there other methods besides drops and irrigation?
Yes, there's manual removal. This is usually done by an ENT specialist or sometimes a specially trained GP or audiologist. They use fine instruments, like tiny scoops or hooks, called curettes or microsection, to directly remove the wax. This might be needed if irrigation isn't safe or hasn't worked.
Okay, so drops, irrigation, manual removal. When is removal actually indicated? When do the notes say you must try to get it out?
Good question. The notes list specific indications. Basically, if the impaction is causing any symptoms, hearing loss, pain, dizziness, tinnitus, and then removal is indicated.
If it's bothering the patient.
Exactly. Also, if the canal is completely blocked, total occlusion. Or if you need to see the eardrum, maybe you suspect an infection behind the wax or a perforation. And definitely for hearing aid users if the wax is causing feedback or stopping the aid working properly.
Those make sense. Now, irrigation sounds common, but you mentioned safety. Are there times you absolutely shouldn't irrigate? What are the contraindications?
Hugely important this. High yield for safety in exams. The notes are very clear. Do not irrigate if there's a known or even suspected perforation of the eardrum.
Right, definite no-go.
Also, if there's a current ear infection or a history of recent ear infections, or if the patient has had previous ear surgery on that ear, or if they only have hearing in that one ear, you don't want to risk damaging their only good ear. Grommets currently in place are another contraindication.
That's a critical list to know. So if irrigation isn't an option, or if initial attempts fail, when should you refer to a specialist, like ENT?
The notes give clear indications for referral. If the patient has a known chronic perforation or complex past ear surgery, if you suspect a foreign body that you can't easily and safely remove yourself, or simply if your standard management to drops, maybe attempted irrigation where appropriate hasn't worked after reasonable tries, then it's time for specialist input.
Okay, and any times that referral needs to be urgent?
Yes, definitely. Urgent referral criteria are listed. If there are signs of infection spreading beyond the ear canal, if the patient has severe or escalating pain, a really key one, if the patient develops vertigo, that's severe dizziness during or immediately after an irrigation attempt.
Vertigo after irrigation is an urgent flag.
Absolutely. Or if you see a perforation after you've irrigated that needs urgent assessment, these situations require prompt specialist management. Remembering these is vital.
Definitely crucial safety points. Okay, so assuming the wax is successfully removed, what's the outcome usually like, the prognosis?
Generally, it's very good, according to the notes. Once the blockage is cleared appropriately, the symptoms, a hearing loss, the fullness typically resolve quite quickly. Hearing should return to its previous baseline.
That's good news, but does it tend to come back?
Yes, recurrence is pretty common, especially for people with those underlying risk factors we talked about, the narrow canals, ongoing hearing aid use, maybe just producing drier wax due to age. The notes mention that good ear hygiene may help prevent it.
And by hygiene, we don't mean more cotton swabs.
No, definitely not. It usually refers to things like regular, careful use of softening drops maybe once or twice a week if you're prone to build up. But that should really be guided by a healthcare professional, not routine poking around.
Got it. So usually resolves well, but keep an eye out for recurrence. What
Yeah.
about things going wrong? Are there potential complications?
Yes, and the notes hopefully break them down. There are complications from the impaction itself and complications from the treatment, particularly irrigation.
Okay, what can the impaction cause?
The impaction itself can lead to recurrent outer ear infections, otitis externa. It can cause temporary hearing loss, obviously. It can worsen tinnitus or dizziness, cause ongoing discomfort or pain. And rarely, as mentioned, severe impaction might theoretically contribute to eardrum perforation, though that's uncommon.
Right, and complications from the treatment, specifically irrigation.
This is where that safety aspect comes in again. Irrigation can cause otitis externa if water gets trapped or the canal gets scratched. Eardrum perforation is a known, though thankfully not frequent, risk of the procedure itself.
A risk from the treatment, too.
Yes, damage or trauma to the skin of the ear canal can happen. Pain during or after the procedure. It can sometimes trigger otitis media, a middle ear infection.
Yeah.
It might make tinnitus worse temporarily. Bleeding can occur, usually minor. Nausea, vomiting, and that vertigo we mentioned are also possible side effects.
That's quite a list of potential downsides to irrigation. Really underscores why you need to check those contraindications carefully.
Absolutely. And there's one more mentioned in the notes, which is rare but serious and definitely worth remembering for exams.
What's that?
Facial nerve palsy. Weakness of the facial muscles on that side. It has been reported, although very rarely, following ear irrigation.
Facial nerve palsy from ear irrigation. Wow.
It's thought to be due to pressure transmission or maybe temperature effects via the middle ear to the nearby facial nerve. It's exceedingly rare, but it just highlights that even a simple procedure isn't entirely without potentially significant risks.
That really does underline the need for proper assessment technique and respecting those safety rules, doesn't it? Turns earwax removal from something routine into something needing real clinical judgment.
Precisely. It demands careful patient selection and adherence to best practice guidelines.
Well, that was a genuine deep dive. We've really worked through these revision notes, starting with the basic definition, why wax gets impacted, who's most likely affected, the symptoms, what else it might be, just how common it is.
Then how to diagnose it, the investigation options.
The management steps drops, irrigation, manual removal, and crucially, when not to irrigate, when to refer, including those urgent flags.
And finishing with the generally good prognosis, but also the potential complications, both from the wax itself and the treatments. We've hit those key learning points.
Yeah, hopefully pulling out the core info you need, especially if you're using this for revision. It shows how important it is to understand even common conditions thoroughly, knowing the differentials, the safe management, the potential pitfalls.
Exactly. It's about more than just getting wax out. It's about safe, effective clinical practice.
So hopefully this has given you listening a really solid handle on impacted earwax. And maybe thinking about those 2 million irrigations, the potential risks, even that rare facial nerve link. Does it make you think a bit differently about seemingly minor procedures and the importance of patient safety across the board?
It's a good point. The details often reveal the true complexity and the importance of thorough knowledge.
Well, thank you for joining us on this deep dive into Cerumen impaction.
My pleasure. Hope it was helpful for your revision.
And if you are revising for the MSRA or just want more high-yield clinical topic summaries like this, definitely check out PassThemsSRA.com. And there's also freemsra.com for great free resources too.
They really are excellent tools for consolidating this kind of knowledge.
Great stuff. That's all for this deep dive. We'll catch you on the next one.